I want to go forward and talk about lung cancer, which is a very important part of the pulmonary section. And let's start off with this case here. A 65-year-old man is admitted because of headache and blurry vision over 3 days. During the examination, you notice neck vein distension and darker skin color on his face than his body. He is confused. The chest x-ray reveals a right upper lobe mass and the serum calcium is elevated. So a couple things you have to think about here that are very important. This guy comes in with a headache and blurry vision over about 3 days, and then on the examination it shows neck vein distension. The color is different. He's darker, right, in his head and his face, right, than the rest of the body. He's confused. And then you do a chest x-ray and you got a right upper lobe mass, and on top of that this patient has hypercalcemia. So right away you should think a couple of things related to this syndrome. This patient has this very interesting syndrome called superior vena cava syndrome, and we'll talk about what to do with this case a little bit later. Now the right upper lobe mass, that's where usually the masses are that cause superior vena cava obstruction. They're usually in the right upper lobe, right? That's where the area where they kind of grow and can obstruct the inferior vena cava. And then they gave you another clue as what the likely cause of the cancer is, because they told you the patient has hypercalcemia. So this is likely associated with squamous cell carcinoma, likely. And then the big question here, since he is confused, and he's got blurry vision, confusion and blurry vision and headache, right? What do you do next in this case? That's a very important question, and we're going to try to answer that with all the stuff that we talk about. So keep that in mind. So some general concepts here. So the leading cause of death from cancer right now in both men and women, this is very important to know, is lung cancer, right? So yes, the most common form of cancer in women is breast cancer, but the most common cause of death from cancer in women is lung cancer. It is much more aggressive than all the other cancers. In men, the most common form of cancer is prostate cancer, but the most common cause of death from cancer in men is lung cancer. So those are two different questions. Please understand what we're talking about. 90% of all the cases related to smoking. All lung cancers are associated with smoking. Please be careful of that. I always hear patients and students tell me, no, adenocarcinoma is not associated with smoking. That is wrong. It is associated with smoking. It is. All lung cancers are associated with smoking. It's just that in the small 10% of patients that are non-smokers, so there's something else that triggers the lung cancer in these patients, most of these cancers are adenocarcinoma. That's a different story, but all 4 types of lung cancer, all of them, are associated with smoking. When a non-smoker gets cancer, yes, it's an adenocarcinoma. Smokers have 10 times the risk of non-smokers, and that depends on the pack years they smoke, but that's about right. And they ask a great question. Well, a patient says, you know, doc, I'm going to stop smoking. When am I going to be, you know, how many years later will I have a normal risk for getting lung cancer, right? What he's asking you is, if you stop today, how many years will it take until they have the same risk as somebody who never smoked? And the answer is never. Really, it's never. 10, 15 years later, their risk goes down to maybe about 2, 1.5, right? And then, you know, 15 or 20 years later, it'll go down to 1.5, maybe 1.2. But those two lines always stay apart. What I really mean is that even though there is a big drop in the chance of getting lung cancer in somebody who has smoked, it never reaches the same percent as a non-smoker. So it's very important, and it's one of the reasons why smokers, when you tell them that, they say, okay, well, I don't need to stop smoking. But in reality, they go from 10 times the risk to, 1.5 times the risk, or 1.2 times the risk. So there's a big, big, big drop after you stop 5, 10 years tobacco. Very important. There is no screening test in lung cancer. There is none. None. Right now, we don't have one. A chest x-ray, not good enough. It's not sensitive or specific. They tried to do cytology, doesn't work. Cytology from sputum. Some people right now are looking into getting CAT scans in patients that are high risk, that have high risk, that have been smoking for a long time. They did this study in Japan, and they showed that maybe a CAT scan done in high-risk patients will catch cancer early on and give the patient a chance. Some people think that this is just a screening bias, that basically they live longer because we caught them earlier, but really when you get lung cancer, it's almost deadly all the time. So for you right now, there is no screening test for lung cancer, no appropriate lung screening test. There are 4 types of bronchogenic cancer: squamous cell and small cell, and you see the C that I put in here because they're usually centrally located, squamous and small cell. The 2 S's are centrally located. Those are the ones that are most important. Those 2, squamous cell and small cell. Squamous cell secretes a parathyroid hormone-like molecule. It grows locally, but it secretes a PTH-like molecule. This activates the osteoclast, and you get hypercalcemia. That's likely what this patient of ours has, a squamous cell cancer with hypercalcemia. Small cell cancer is deadly, very aggressive, right? Most people say non-curable disease. They tell you, yeah, it does well with chemo, but it's non-curable. And this one does all the other paraneoplastic syndromes, like Cushing syndrome, like SIADH, like Lambert-Eaton syndrome, all these, endocrine-like diseases. Be aware that if you're looking at paraneoplastic syndrome and it's not hypercalcemia, think about small cell cancer. And then we have the 2 peripheral ones, large cell carcinoma and adenocarcinoma. I already told you about adenocarcinoma being common in non-smokers, but it's still related to smoking. And then a type of adenocarcinoma, bronchoalveolar carcinoma, which is very interesting. It's kind of like a low-grade cancer, but it can occur with multiple sites on the same lung or involving both lungs. Very important, because sometimes they give us an x-ray with multiple lesions on the x-ray and they say, what is this? And you think about metastatic disease, you think about other infectious causes, but you never think about primary lung cancer. And this is the type that you should think about, bronchoalveolar cancer, because they ask us, could this be cancer? And the answer is yes. It could be bronchoalveolar carcinoma. So how does a cancer, lung cancer, present? The most common symptom is cough. It's nonspecific, but that's what most patients that have lung cancer, symptomatic lung cancer, that's what they have. They always have cough. And then a combination of some other symptoms, either weight loss, a little bit of dyspnea, and maybe some hemoptysis. There's a couple of syndromes, though, that are associated with the presentation of lung cancer that are very important, and they ask us questions on them. So, for example, sometimes a patient with cancer could present with recurrent pneumonia. So they tell you, well, this guy came in 6 months ago and had a right middle lobe pneumonia. We treated with the antibiotics, he got well, felt great, and now he's back 6 months later with cough and fever of a couple of days, and he's got leukocytosis, and we do the chest x-ray again, and here's this other, big infiltrate, right middle lobe infiltrate. And this patient, you always have to be concerned about when you find recurrent pneumonias in the same area in patients, especially high-risk patients for lung cancer. And what this type of pneumonia, what this guy has, is post-obstructive pneumonia. I use the right middle lobe because it's a common area where you could get post-obstructive pneumonia, and it's an area where you don't get aspiration pneumonia. And you have to think about that. Recurrent pneumonias in somebody who's high risk, think about maybe there's an obstruction there, probably lung cancer. Wait for the pneumonia to go away. Maybe get your friendly pulmonologist to do a bronchoscopy and look there and make sure they don't have cancer. The other thing that we are asked sometimes is hoarseness. Now, hoarseness means that the cancer itself has metastasized to the laryngeal nerve, right, and the vocal cords. And this case is not only that you have to think about it when a patient gets hoarse, that you have to think about lung cancer, but right away you know something about this cancer, that it's metastatic already. And metastasized lung cancer outside the lungs, it's unresectable. So if they tell me which of these patients you think we could, treat for, resect, do surgical resection, they have lung cancer, when I hear a patient with hoarseness, right away, I'm saying like this is probably not a candidate unless they have the hoarseness for some other reason. Because hoarseness from lung cancer means metastatic disease already. The ENT people look at the vocal cords and they find the lesions, they biopsy them, and they make the diagnosis. The superior vena cava obstruction syndrome is what our friend came in with, the case that we just did right here. And he came in, if you remember, with blurry vision, confusion, and so forth, and the change in the face, right, the color, the distended veins, and so forth. That's typical of SVC syndrome. Now, most of the cases of SVC syndrome, the mass, the lesion, is in the right apical area. Right apical area, a superior sulcus tumor obstructing the vena cava. Now, this disease is sometimes an oncologic emergency. When the patient has blurry vision, when they have headache, when they're not responding, when they're confused, that is an oncologic emergency. You have to put the patient in the hospital quickly, and what you have to do, you have to get the radiotherapist, the people who do the XRT, they have to come down and they have to radiate this area and shrink the tumor. Shrink the tumor so they resolve the obstruction, or the patient will die. If the patient has superior vena cava syndrome and doesn't have, confusion, doesn't have blurry vision, you may have a short window in which you could try to go in there and make a tissue diagnosis of the cancer. Now that's very important, because if you radiate the area, you won't be able to see what kind of tissue you got. So you lose the diagnosis. You save the patient, you lose the diagnosis, so you have to speculate. So if you could get your team together really quick, get them in, make a tissue diagnosis before the people radiate the area. Sometimes we don't have that choice. Sometimes the patient is getting worse and worse in front of our eyes, so we have to radiate the area. But ideally, if you have a small window opportunity, the patient's not that confused, they don't have a lot of blurry vision, you could wait a half a day, get the surgeons and the pulmonary people to go in there, take a chunk out of the tissue there to make a diagnosis, and then radiate it and shrink it. A lot of these are squamous cell cancers. In our guy, that's what it was, and we knew that because he had the hypercalcemia. He had the hypercalcemia from the parathyroid hormone-like molecule secretion. Superior vena cava syndrome is a common question they ask us. They may show us a picture of somebody with the distended veins, change in color, the face versus the body, and they tell you this patient has been confused for a couple of days or has a headache. What does he have? He has a tumor in the superior sulcus. The Pancoast syndrome is another syndrome that can occur because of a right apical tumor, a right superior sulcus tumor. And the Pancoast syndrome is because the tumor has invaded the brachial plexus. This tumor sometimes is called a Pancoast tumor, but the syndrome, it's a neurologic syndrome where these patients develop neuropathy, painful neuropathy of the right upper extremity because of the invasion from the tumor to the brachial plexus. Then we have the Horner syndrome. Horner syndrome, again, probably a right apical tumor. All these three right apical tumors: superior vena cava, Pancoast, Horner syndrome, right apical tumors. The Horner syndrome, now you have disruption of the sympathetic chain. So this patient has ptosis, anhidrosis, meiosis. All these three syndromes are potentially treatable. What I'm really saying is, most lung cancers, once we diagnose them, they're non-resectable. But having superior vena cava syndrome or Pancoast syndrome or Horner syndrome doesn't mean right away that this is non-resectable. You have to do the appropriate staging. They may be resectable. Usually lung cancers are not. So please be careful. If they give you something that a patient has Horner syndrome or SVC syndrome, it doesn't mean that right away, by definition, this is unresectable. If a patient has lung cancer and hoarseness from the lung cancer, that's unresectable. It has metastasized outside the lung, and you can't do anything about it. A fusion is the last thing I want to talk about. Most cases of lung cancer and associated effusions are unresectable, because if the lung cancer goes outside of the lung anywhere, it's unresectable. If the lung cancer goes to the pleura, it's unresectable. It's outside the lung, and it causes the effusion there in the pleura, basically invades the pleura. And what you could do to make a diagnosis is do a thoracentesis, take the fluid out, spin down the cells, and find the malignant cells. And not only now you've diagnosed the cancer, but you also know that it's stage 3B and it's unresectable usually. So I hope people understand that when I see cancer in the lung or something that looks like a cancer, this guy has a fusion, I'm not going to go for that cancer first, right, and get the pulmonologist to go down there. I'm going to go for the effusion, because if I find the cancer cells there, I got my diagnosis and I got my staging at the same time. So do the right thing there. Go for that thoracentesis right away. So effusions and cancer, they're usually unresectable in about 80–90% of the time. Sometimes, rarely, you could have a post-obstruction pneumonia from the cancer, and the pneumonia itself now causes the effusion, and that's not, unresectable. So they're not all of them are unresectable, but most of them are. Most cases of effusion related to lung cancer are unresectable. Diagnosis is made from a couple of ways. Sputum cytology, if we could get sputum cytology, we could get a good, adequate specimen. It happens in about 1/3 of the cases. You can make a diagnosis. If you find cancer cells in the sputum with a lung mass, you don't have to go any further. So look for simple ways to make a diagnosis a lot of times, especially when it looks like it's an unresectable cancer. Most of the time, the way we put the diagnosis or clinch the diagnosis is through bronchoscopy for central lesions or needle biopsy for peripheral lesions. Bronchoscopy has, the pulmonologists have really gotten savvy with bronchoscopy, and they will go after central lesions and a lot of times even peripheral lesions and take a good chunk and make the diagnosis. If a patient has a lung mass, even if the bronchoscopy results come back non-diagnostic, showing only inflammatory cells, this patient still likely has lung cancer. Remember, I said this is a blind biopsy, and sometimes you don't get the right chunk of the cancer that you want to make the diagnosis. So be careful of that. If you're thinking about lung cancer and that's negative, you got to go one step further. Resect the mass or go in and take a chunk of the mass and so forth. Cytology after effusion drainage is the way to go. Right here is the way to go for all effusions. Please look at that. They may ask us a question about that. A guy has a lung mass and a pleural effusion. What is the best way to find to work up this case? The answer is go for the effusion. You'll get two answers. Is it cancer? And then you'll get the staging right away. For all other stuff, difficult stuff that you can't get into, you did the bronchoscopy, you couldn't get it, you did all the stuff, and you couldn't get it, you're left with mediastinoscopy. This is a more aggressive procedure, but sometimes we have to do it. So think about that, how to diagnose the lung cancer with easy ways before you go to the more aggressive maneuvers. So what do we do after we diagnose lung cancer? So our first question, there's two basic questions. The first question is the cancer resectable, right? And we do a combination of CAT scans, sometimes MRIs to look for metastatic lesions. And now you're going to hear about this positive emission tomography, a PET scan here, which is coming up really quick, really quick. What the PET scan does is it evaluates the glucose uptake of certain cells. Supposedly, malignant cells have a quick uptake. So they take this up really quick and they light up. So, for example, you could do a whole body PET scan and find small metastatic lesions outside the lung. And right away that tells you it's non-resectable. Please be careful. There was a big article about evaluating lung masses with PET scans. And it said, yes, most lung masses, if they're cancer, the PET scan should light up because the mass itself is going to, the cells are dividing quickly. They take up glucose really quickly, so it's going to light up. But there are lung cancers that are very slow growing, and they don't divide really quick. The typical one is bronchoalveolar carcinoma, the one that occurs, it's type of adenocarcinoma and may occur in non-smokers. So please be careful when you're evaluating lung masses and lung nodules. Please, the PET scan is not the way to make a confirmatory diagnosis. Please don't tell a patient, listen, your PET scan is normal, that you don't have lung cancer. That mass is something benign. Remember what we said with the lung nodule? You got to get tissue there if the patient is high risk. So please be careful of that. But you'll see a lot of talk about the PET scan. It's really coming up. A lot of people are doing it to evaluate patients for metastatic disease and so forth. If the cancer is resectable, let's say it is resectable, it's confined into the lung, is the patient a surgical candidate? And remember, I told you that a lot of patients, even though they have a resectable cancer, if their lungs have extensive chronic obstructive lung disease, then the cancer becomes unresectable. And the cutoff is the FEV1 and the FVC sometimes. They tell you it has to be at least 50% of predicted. So they take a big chunk of your lung out because you got lung cancer. Well, the rest of the lung is pretty much okay there, and you have a lot of lung left. So please, nobody goes to surgery for lung cancer before they do a pulmonary function test. If they ask you what is the next step in the surgical management of this patient, they're not asking you, what type of surgery are we going to do for this patient. They don't want you to know stuff like that. They want you to know that this patient will get pre-op evaluation in order to go for surgery with pulmonary function tests. They definitely need you to know that. Now, just briefly, just to keep we don't need to know staging in lung cancer, but this is what you need to know. If a patient has lung cancer and it has metastasized outside the lung anywhere, it's non-resectable. If it has metastasized to the pleura with an effusion, it is unresectable. If it has metastasized to the other lung, it's unresectable. If it is close to the carina, the main bronchus there, it is unresectable. If you remember those four things, that's all you need to know about staging. So let me repeat that. Outside the lung, unresectable anywhere. Other lung, unresectable. Pleural infiltrates and effusion, unresectable. Close to the carina, unresectable. Now, some people have looked into a very interesting case of patients. If a patient has a small lung mass with a single metastatic lesion to the brain, some people will attempt surgery. The neurosurgeon will take the central lesion out, and then the cardiothoracic surgeon will take the lung cancer out, only when they have a very small lesion. So that's the only exception to what I just said right now, that a small lesion to the brain with a small lesion to the lung, they may take both of those out. The studies show that these people will benefit. A lot of them will benefit. So that takes care of management after management after diagnosis. And I want to tell you a little bit about the non-resectable cancer that we just talked about. And I just want to make sure that you solidify all the staging stuff. Hoarseness is unresectable, right, because it's outside the lung, right? Metastasized to distant organs, unresectable, right? We just said that. The exception is the single met to the brain with a small lung cancer, right? Metastasis to the pleura and effusion unresectable when you find cytology positive there because it's the pleura. Metastasis to the lung unresectable, and lesion close to the carina and main bronchus unresectable. The fifth one, they're not likely going to ask you. It's one of the other four. So basically for your boards, all you got to know is it resectable or non-resectable? That's the end of the story. They will not ask you definitive staging systems in lung cancer. Your thing is, when do I really go after this patient and try to get all the stuff and try to get a resectable cancer versus, you know, somebody that, well, I shouldn't do a million tests because it's unlikely unresectable. That's the bottom line. That ends the lung cancer section.